the pediatric hematologists at Evelina London Children's Hospital. This presentation, Pediatric Sickle Cell Emergencies, is for healthcare providers who evaluate children with sickle cell in the emergency room to allow for prompt, thorough, and appropriate assessment and management. Over the next 30 minutes, I will briefly review pathophysiology and some of the complications of sickle cell disease, the management of acute painful episodes, fever, anemia, neurological symptoms, priapism, and end with a brief summary. As we all know, sickle cell is a hereditary hematological disorder where the sixth amino acid on the beta globin chain, glutamic acid, is substituted by valine, which is a non-polar amino acid. This alters the solubility of hemoglobin S, particularly when it's deoxygenated or there's dehydration or acidosis. So instead of red cells being flexible and donut-shaped and squeezing through tiny red blood cells, red cells from people with sickle cell disease are stiff and angular and cause them to become stuck in very small capillaries. This causes decreased delivery of oxygen to the tissues, can result in ischemia and pain, and eventually can cause necrosis of some of these tissues. It is also well known that sickle cell disease is also an inflammatory disorder. There's activation of the white cells, there's activation of the endothelial cells, and platelet activation. This results in pro-inflammatory cytokine production, and this can present with fever. There's also expression and activation of cell adhesion molecules on endothelial cells, platelets, and leukocytes, and causes the red cells, the white cells, and the platelets to aggregate together. Sickle cell disease is also a hemolytic disorder, and the red cells do not survive as long as normal red cells do. As a result, people with sickle cell disease have complications that affect all of their body. The most common complication are acute pain episodes. And in infants, these can present as dactylitis or swelling of the hands and feet. But as children go older, pain can occur at any part of the body. From a very young age, there are kidney problems in children with sickle cell disease. They are unable to concentrate urine as well as other people do, and therefore they produce large amounts of dilute urine. In the first decade of life, children can spill urine into the protein and can sometimes present with hematuria. One of the most common causes of mortality in people with sickle cell disease is acute chest syndrome, which can be a pneumonia or an infarct of the lung. Children as young as 1 year of age may have a stroke or have silent infarcts and can experience intracranial hemorrhages. In the first or second decade of life, as a result of the hemolysis, children may develop gallstones or may have sudden enlargement of the liver, called a hepatic sequestration. Similarly, the spleen does not function very well in children as young as 1 year of age. They may also develop a splenic sequestration. As a result of the poor function of the spleen, people with sickle cell disease are at increased risk for infections. Young boys and teenagers can present with priapism or painful erections, and then young children can have leg ulcers as a result of the hemolysis. Now, whenever children or adults with sickle cell disease present to A&E, they do need a minimum number of laboratory studies, and this should include a full blood count, and it is always very important to obtain a reticulocyte count at the time they present. This will allow you to manage the patient more appropriately. When they attend, because many people will require blood transfusion, it is important to obtain a group and save and to make sure that the fact that the person has sickle cell disease is on the request. This is because people, if they require blood transfusion, the red cells are matched in an extended phenotype compared with normal people, and therefore it's helpful for the lab to know this at the time of receiving the sample. One should obtain a urine renal profile and liver function tests and a CRP. In addition, if the person has a temperature anything greater than 38 degrees Celsius, a blood culture should be obtained. If the person has received a blood transfusion within the last 3 months, a percent hemoglobin S should be obtained, which can be obtained by requesting a hemoglobin electrophoresis. The most common complication of sickle cell disease are acute painful episodes, and this is because there is decreased oxygen delivery or ischemia, an infarction or necrosis, and inflammation. We do know that the bone marrow has nociceptive nerve fiber endings, which are very sensitive to pain. Now, painful episodes can occur spontaneously, but can be precipitated by changes in temperature, such as when it becomes very hot in the summer or very cold in the winter. They can occur with infections, emotional stress, dehydration, hypoxia, and physical overexertion. We ask our patients to attend the hospital at any time they have difficulty breathing, fever, vomiting or diarrhea, severe headache, lethargy or listlessness, or persistent pain despite regular analgesia. Now, the UK standards for pain management in A&E for people with sickle cell disease is that the pain should be assessed upon presentation to A&E. And patients should receive pain medications within 30 minutes of presentation. And they should be reviewed every 30 minutes to assess how well the pain relief is going. And if patients have received strong opioids, they should have a clinical assessment every hour for the first 6 hours that they are in hospital. And it is important to listen to the patients and the family, since they are the most aware of their condition and how it responds to medications. Now, when patients attend the hospital for pain, it's important to consider the following things: what medications they have used already, both at home and what they have received in the ambulance, the location, how long they have had the pain, the intensity of the pain, and the impact on their life. For example, is it interfering with them going to school, sleeping, or are they able to continue their daily activities, playing, reading, despite having the pain? Are these their typical pain symptoms? Are there any other associated symptoms such as vomiting, diarrhea, and constipation? It's always important to get their vital signs, including blood pressure, heart rate, temperature, and oxygen saturation, and a very careful physical exam. Now, most people who present to A&E with a pain episode will have a completely normal physical exam. But sometimes at the site of the pain, there can be warmth and swelling. This can often make it difficult to discriminate between an infection or a pain crisis. In addition, it's important to listen to the chest for any chest findings, such as crackles or wheezes, and to examine the abdomen for hepatosplenomegaly or any particular tenderness. Now, infants are a special case because obviously they cannot tell us what their typical pain symptoms are, or even if they are having pain. They will typically present with irritability and an inability to comfort them despite having been fed, changed, and cuddled. Sometimes they may have painful swelling of their hands and feet, as is shown in this picture, but sometimes the physical exam may be completely normal. Now, many people, when they come to the hospital, especially using an ambulance, will receive inhaled nitrous oxide or Entonox as a form of pain relief. And this is quite effective for immediate analgesia and does not require intravascular access. However, it is quite short acting. It is not advisable for prolonged use, but it is important to be aware if they've already received Entonox in the ambulance, since when the patients arrive in the hospital, they may appear quite comfortable. However, the effect of Entonox will wear off pretty quickly. And if they do not receive any further stronger pain medication, they will be rapidly in another worsening pain. However, we do not advise using Entonox in the hospital because prolonged use can result in hematological toxicity and neurological toxicity. Therefore, it is better to look for more long-acting options in these patients. Now, how do we measure pain? Sometimes we can just look at the patient and be completely aware that they have an enormous amount of pain. In children over 3 years, we're able to use the FACES scale, and they're able to point out where they feel their pain is. And as people become older, we use the number scale, where 0 is no pain and 9 to 10 is the worst pain they ever would have. Now, management of pain requires a holistic approach. So we use a number of pain medications to help manage the pain. We sometimes have to give medications to treat side effects of pain, and also have to try and figure out what is provoking or making the pain worse and try to address those things. We will usually use a combination of 3 different groups of pain medications. So we'll use a combination of nonsteroidal anti-inflammatory drugs, such as ibuprofen, naproxen, or diclofenac. Ibuprofen is given orally and should be given at a high dose, such as 10 milligrams per kilo. Diclofenac can be given rectally in case the patient has difficulty keeping things down. Paracetamol can be given orally and intravenously. And then it's good to choose one of the following narcotics. Now, dihydrocodeine is often used by our patients at home, so if they've already used this quite regularly at home, it is suggested to use something stronger. When patients arrive in the hospital, if they need a stronger narcotic than dihydrocodeine, we will often prescribe diamorphine intranasally. This allows us to give us quite strong pain medication prior to having to place a vascular, prior to achieving vascular access. One can also give Oromorph orally, however, that takes a little bit longer to act. And once they have a cannula in place, morphine can be given either as a bolus or morphine PCA. It's always important to try and use some non-pharmacological options, such as stress relief, if possible, warm packs, and some distraction therapy. For young children, this can be using a computer game or looking at a funny movie on a TV. And older patients can use computer games sometimes with this. And it's always important, as we said, to treat some of the side effects of the medications we're using to treat pain by giving a laxative, antiemetics, and antihistamines for people on morphine, since they can have itching or significant nausea associated with this. When patients are in a lot of pain and receiving large amounts of narcotics, they tend to be quite sleepy and take very shallow breaths and may end up with atelectasis. So once they are on narcotics or have any chest pain, we usually ask them to do some incentive spirometry to prevent atelectasis. Now, pain management in this group of patients is quite challenging. So there is no laboratory method to measure how much pain a patient is in. The only way to find out how much pain a patient is having is to ask the patient or their parents. And that is the gold standard for pain assessment. There is also quite a fine line between achieving adequate pain relief and avoiding over-sedation. A lot of narcotics, which will provide enough pain relief, may make our patients quite sedated, and we have to monitor this quite closely. Patients, when they are in pain, can be quite irritable, they are frustrated, and sometimes are non-conversive, making them sometimes hard to figure out how much pain they are actually in. And additionally, this group of patients often has many psychosocial needs. Many children with sickle cell disease live in poverty. Some of the housing is overcrowded. It's not adequately heated. It's very damp, and all these conditions exacerbate pain crises. Some patients have significant immigration issues and will not attend the hospital until they have significant amounts of pain and require quite a long time before we get this pain under control. Many of these patients may not have come from single parent families, have lots of other children at home that need to be managed, and this can make it quite difficult and challenging to manage the patients. And if we can help support the patients through these issues, it might make the pain much more manageable. In addition, younger adults, if they've had silent infarcts or strokes, they may have some cognitive decline, making it difficult for them to understand their treatment plans and to adhere to the treatment plans. Now, cannot overemphasize that when we manage these patients for their pain, we need to have frequent assessments. In the beginning, every half hour to every hour to make sure they're getting adequate relief and are not over-sedated, to make sure we are managing the side effects of the medications such as pruritus and nausea, and to make sure they are adequately oxygenated and they are not over-sedated. Now, children with sickle cell disease are at increased risk for infections, and that's because from a very young age, from the first year of life, they have decreased function of their spleen. This puts them at risk for severe infections with encapsulated organisms such as strep pneumonia, Haemophilus influenza, and meningococcus. People with sickle cell disease also have decreased ability to make antibodies to strep pneumonia. In addition, once they've had many pain crises, the tissue ischemia and necrosis provide a good site for further bacteria to grow. Now, over the past decade, comprehensive management of people with sickle cell disease has decreased the risk of these severe infections. First of all, we have universal newborn screening. Therefore, people who have sickle cell disease are diagnosed within the first 6 weeks of life, and they are started on penicillin prophylaxis as soon as they have been diagnosed with sickle cell disease. We have very good vaccinations. All people in the UK, children in the UK, receive Prevnar and H-flu vaccinations. We also give our children the 23-valent pneumococcal vaccination at 2 years and then every 5 years. And all children are receiving hepatitis B vaccinations. And then we ask our patients to attend the hospital whenever they have a temperature greater than 38 degrees Celsius. And when they come to A&E, we want to make sure that they have very prompt attention and management. There's a very threshold to admit these children, especially when they're less than 1 year of age. It's also important to obtain a travel history, and especially looking to see if they have gone to malaria-prone countries. Now, they should have a careful evaluation for a source of an infection, including a blood and urine culture, an examination of their throats and ears. A respiratory viral panel and chest X-ray should be obtained for those who have decreased oxygen saturations or respiratory symptoms. And they should get antibiotics within an hour of presentation. And this is another UK standard. We usually choose a broad-spectrum antibiotic, such as ceftriaxone. If they have pulmonary symptoms, we will add a macrolide, and I will discuss the reason for this shortly. We do not recommend that you just double up on penicillin prophylaxis, treat the fever with antipyretics alone, or hold off antibiotics, awaiting for the patient to produce a urine sample. So ideally, patients with sickle cell disease, when attend the hospital who have a fever, should have a careful but quick review for a source for fever, They should have blood cultures obtained in addition to a full blood count and CRP, and receive an antibiotic within 1 hour of presentation to the hospital. They should be admitted at any time they have ill appearance or high CRP, if there's an oxygen requirement, if there are any safeguarding issues, if they have associated significant pain, especially if it's in the chest or the abdomen, and there's a history of a poor compliance with appointments, and if there's concern that if they leave the A&E, we will have difficulty getting hold of the parent and the family. Ambulatory management, therefore they can receive their broad-spectrum antibiotics and subsequently either receive oral or further broad-spectrum antibiotics at home. If they are very well appearing, laboratory studies are reassuring, meaning the CRP is less than 30, the white blood counts less than 28, and we feel we can do a follow-up in 24 hours, either by phone or face-to-face. Now, acute chest syndrome is now the most common cause of mortality in sickle cell disease, and this is defined as having chest pain plus and minus fever with a new infiltrate on chest X-ray. The etiology could be an infection such as bacteria, viral, or mycoplasma and chlamydia. It could be infarction or necrosis of a piece of lung or fat embolism. This occurs, for example, when a patient has a painful crisis. They have necrosis of a small piece of bone marrow which embolizes to the lung, resulting in acute chest syndrome. There was a large study which investigated 671 episodes of acute chest syndrome in people with sickle cell disease. And when they were admitted to the hospital, they had a very large investigations, including blood cultures, urine cultures, respiratory viral panels, and many also had bronchoalveolar lavages in an attempt to identify an infective organism. And they were able to identify an infective etiology in about half of these patients. And as you can see from this table, the most common infective organism identified was chlamydia pneumonia in 71 of patients, followed by mycoplasma pneumonia by 51. And in the others, there are the other common infective organisms such as RSV, Staphylococcus aureus, Streptococcus pneumonia, and so on. And that is why when we treat patients with acute chest syndrome, we will add a macrolide to cover the organisms chlamydia pneumonia and mycoplasma pneumonia. Now, acute chest syndrome should be treated with antibiotics, so broad-spectrum antibiotics such as ceftriaxone and a macrolide. Patients should receive hydration, but care should be taken not to overhydrate these patients, so they should receive fluids at 3/4 of maintenance, and this could be intravenous or intravenous and oral combined. They should also receive adequate analgesia, enough oxygen to maintain saturations greater than 95%, and incentive spirometry to prevent atelectasis. They should also be monitored frequently for respiratory deterioration and have frequent physical exams. Now, if there is an oxygen requirement and a significant infiltrate, and the hemoglobin is low enough, we will often perform a top-up transfusion with sickle-negative blood for these patients. However, if despite this the patients continue to deteriorate or have a very rapid deterioration, we would proceed with an exchange transfusion. In addition, if when the patient is in the hospital has quite a high hemoglobin and cannot tolerate a top-up transfusion, they will need an exchange transfusion. This may occur in children with hemoglobin SC who have rather high hemoglobins at presentation. Now, in the long term, people who've had an acute chest syndrome should be advised to have treatment with hydroxycarbamide or transfusions if hydroxycarbamide is not successful, since Once someone's had an acute chest syndrome, they're on increased risk to have further acute chest syndromes and can subsequently develop more chronic lung disease. Now, sometimes patients will present with abdominal pain as the site of pain. One can have abdominal pain as the site of an acute painful crisis, but one also has to think of other common causes of abdominal pain, such as constipation, especially in those who are using large amounts of narcotics. You should also consider the presence of a urinary tract infection or gastroenteritis. This could be associated with either dysuria, vomiting, and diarrhea. Sometimes an acute painful episode in the abdomen can mimic acute appendicitis. So sometimes patients will have significant tenderness and even rebound tenderness. So in those patients, it might be helpful to obtain either abdominal ultrasound or CT of the abdomen to evaluate for appendicitis rather than proceeding directly with surgery. And young women with periods may have dysmenorrhea presenting with abdominal pain. Now, less commonly, but should be considered in people with sickle cell disease, is the presence of cholecystitis, especially if there's a history of gallstones, a splenic sequestration. This would present with an enlarged spleen, acute parvovirus infection, a hepatic sequestration, which will present with hepatomegaly, and gastric ulcers, especially if there's very frequent use of nonsteroidal anti-inflammatory drugs. So when someone presents with abdominal pain, it's important to ascertain the presence of nausea, vomiting, diarrhea, or constipation. If this is where they usually have their pain, if there's been a history of gallstones, if their pain occurs after eating fatty foods, what medications they are taking, and evaluate them for jaundice and dysuria. On exam, pay careful attention to the abdominal exam. And in the labs, in addition to the usual sickle cell labs I've discussed, it's important to think about adding an amylase to look for pancreatitis, obtain a blood cast and look at the lactate, a urine culture and stool sample, if pertinent. And then also, if there's a very low reticulocyte count, perform parvovirus serology. One may need to obtain an abdominal X-ray or an abdominal or renal ultrasound. If there is signs of an acute abdomen or a silent abdomen, it will be important to obtain a surgical review and keep the child nil by mouth. If the patient has a fever or very ill appearing, it's important to give them antibiotics, always within 1 hour of presentation. And the choice of antibiotics, if there is significant abdominal pain, should be enough to cover, in addition to the gram-positives, gram-negatives, and anaerobes. So it could be a combination of piptazocin and gentamicin, or vancomycin, ciprofloxacin, and metronidazole. Now, some patients, when present to A&E, will have worsening anemia. How is this defined? Well, it's defined a hemoglobin, which is 20 grams per liter lower than the usual hemoglobin, or any hemoglobin less than 50 grams per liter. Now, obviously, patients don't come in and tell you that they have worsening anemia, but they will usually present sometimes with a fever, fatigue, worsening pain, pallor, increased jaundice, sometimes with difficulty breathing and dizziness. On exam, they may have a completely normal exam, but may have rash, may be pale. In people of African heritage, it's sometimes difficult to tell that they are pale, so it's always helpful to look at their palms of their hands or the conjunctiva, where the pallor might be more obvious. Also to examine them for splenomegaly or hepatomegaly, and pay attention to the heart rate. Now, if you do notice that they have a significant anemia, this is where the reticulocyte count, which was obtained upon arrival to A&E, will be extremely helpful. If the reticulocyte count is very high and generally greater than 200, and they have enlarged spleen, one would be concerned for a splenic sequestration. If there's an enlarged liver, one would be concern for hepatic sequestration, and if the exam does not have an enlarged liver or spleen, then one would worry more about increased hemolysis. However, if the reticulocyte count is less than 100 and particularly very low, sometimes as low as 0, then we think about a red cell aplasia, often due to infection with parvovirus B19. Now, splenic sequestration usually occurs in very young children, ages less than 3 years of age, with homozygous sickle cell disease, but may occur later in children with hemoglobin SC, S beta 0 thal, or those who are on regular red cell transfusions, and is noted as a new splenomegaly or an increased splenomegaly if they have splenomegaly at baseline. Some patients present in a very severe way with collapse, shock, fever, lethargy, tachycardia, and hypertension. So often these patients are extremely ill at the time of arrival to A&E. However, sometimes they may just present with anemia or pancytopenia, but may be quite well appearing. Now, if they present with shock, they should be resuscitated with IV fluids and emergency blood, such as group O Rh negative. These are patients who are hypotensive and extremely tachycardic and lethargic. However, if they're relatively well appearing and they require blood transfusion, one could await appropriately matched blood to transfuse them, targeting a hemoglobin up to 100 grams per liter. We generally want to avoid transfusing patients with sickle cell disease to hemoglobins greater than 100, because then there's increased viscosity of the blood and can result in more complications. One would also consider giving intravenous antibiotics and monitoring these patients quite closely. They often require an admission, especially if they require transfusion or at least observation. Now, once a child has had a splenic sequestration, they are at increased risk to have further splenic sequestrations, and especially if they have had a severe case, they may require a splenectomy or sometimes chronic transfusion. Now, if a child presents with severe anemia and very low reticulocyte count, as mentioned before, this is due to red cell aplasia, and usually due to infection with parvovirus B19. However, either viruses can cause a red cell aplasia. These children will present sometimes with lethargy, pallor, sometimes with a pain crisis, and some may have joint pains. And they may also have other cytopenias, thrombocytopenia and leukopenia. It is important to send off parvovirus serology, and also to a PCR, since the PCR may come back within 48 hours, and one will have the specific diagnosis sooner. If they have severe anemia, they will require blood transfusion. Now, it is important to be aware of the reticulocyte count before the child is admitted to the hospital. And this is because they should be isolated on the ward, and they shouldn't be nursed by staff that is pregnant, especially in the first trimester. Since if that staff member were to get parvovirus, this could have a lot of consequences for the child. So ideally, before a child with sickle cell disease and severe anemia is sent to the ward, a reticulocyte count is obtained. And if it's less than 100 or very low, they should be isolated until the parvovirus serology is back. Some patients will also require, in addition to a transfusion, may require some intravenous fluids, antibiotics if they have a fever, and analgesia if they're presenting with pain. Now, some patients will present with neurological symptoms to A&E, such as a severe headache, neck stiffness, photophobia, altered behavior, hemiparesis, ataxia and aphasia, and some may present in a coma. Some may present with an acute neurological deficit, but that has already resolved, a transient ischemic attack or a seizure. Now, most common thing that can happen is a stroke in these children, which used to occur in up to 10% of sickle cell patients less than 10 years of age. This most commonly occurs in children who have homozygous sickle cell disease or S-beta thalassemia. However, they can present with a subarachnoid hemorrhage, meningitis, encephalitis in absence, just like other children. Sometimes a vaso-occlusive crisis of the calvarium can present with severe headache. They may have ingested some medications or toxins. They may have just had an episode of syncope. They may have cerebral sinus vein thrombosis or posterior reversible encephalopathy syndrome, and rarely could have a tumor. Obviously, the first important thing to do is to have neurological stabilization, control the seizure if that's occurring, manage any hypoglycemia, and give antibiotics for potential infections. It's important to send off the labs urgently, and in this case also include a coagulation screen and blood gas, and urgent imaging. A CT of the head will allow one to detect a bleed quite rapidly and can be done in many A&Es right away. MRI, MRA, and MRV would be recommended of the head. However, in young children, this may require sedation or even anesthesia, so it may be difficult to obtain in A&E, but can be planned. Any patient who presents with a severe neurological event such as this should be discussed with the neurology team and also with the sickle cell team urgently. They often will require a top-up or exchange transfusion and an admission to appropriate ward and center. Now, priapism is something that can occur in young boys and teenagers with sickle cell disease. And this is defined as a prolonged, painful erection, and this is due to vasoocclusion in the vessels in the penis. It's more common in adults, but we have seen it in very young children and teenagers. Now, sometimes priapism is called stuttering because it only lasts a few minutes, goes away, but then recurs quite frequently. But the total duration time is usually less than 2 hours, and it's usually episodes of minutes and goes away and comes back. We recommend that if patients are having these episodes at home, especially if they're stuttering, that they may take fluids, have warm baths, they attempt to pass urine, have analgesics, and do some exercises. However, if they have a prolonged episode, anything lasting longer than 2 hours, they should attend hospital. Now, when they come and have such an episode, they should be kept nil by mouth and placed on intravenous fluids at maintenance. One should obtain the appropriate laboratory studies, and one should obtain an urgent pediatric urology consultation and review. Now, if you don't have pediatric urology in your hospital, then consult a center that does have experience with sickle cell disease and a pediatric urologist on call. Often these children will require a penile aspiration or irrigation or rarely shunting. Now, other treatment options that can be considered are an exchange or a top-up transfusion. However, this is not necessarily going to correct the problem. Sometimes a medication, such as epinephrine, can be helpful. It is important that this is managed appropriately, since patients who have repeated, prolonged, and untreated episodes can end up with impotence as adults. So I hope I have provided you some information about prompt and thorough management of children with sickle cell disease in A&E. I can summarize and say that sickle cell disease is a challenging and multi-system condition to manage. It is very important to listen to the patients and their families, and prompt and thorough assessment are necessary. And I cannot overemphasize that even in A&E, but also on the wards, frequent assessments are important. Thank you for your attention.